So welcome to my name is Jeff Levy with Trust for America's Health and the George Washington University. We are now about to start a panel entitled Population Health Research Priorities, Perspectives from the Field, or now we're going to get real. So this is a panel of folks out in the real world who we hope we can reach with our population health research, and they're going to tell us a little bit about their needs, but also, I think, how we frame those needs to better reach the audiences they work with. You have their full bios, but from this end to that end, I can't, which, you know, your left, I guess, to your right. We have LaMar Hasbrouck, who's Executive Director of the National Association of City and County Health Officials, or County and City Health Officials, excuse me. But he, in his prior life, and I think probably even more relevant to this panel, was a state health officer and a county health officer. Next to LaMar is Ron Pollack, who's Executive Director of Families USA, an organization that has had a prominent role for some time in doing evidence-based advocacy around health reform. Next to him is Linda Elam, who is Deputy Assistant Secretary for Disability, Aging, and Long-Term Care Policy in the Office of the Assistant Secretary for Planning and Evaluation in the U.S. Department of Health and Human Services. But that is the office, that's a long way of saying that's the office that really can generate and support lots of research, as well as use and translate research for policymakers in the Department of Health and Human Services. And last but not least is Janelle Krishnamurthy, who is Executive Director for U.S. Policy and Government Relations at Merck & Company, and prior to that was the Chief Health Staffer in the Health, Education, Labor and Pensions Committee of the United States Senate, working for Tom Harkin. And were it not for Janelle's work in support of Senator Harkin, we would not be here for the last few days talking about all those opportunities in the Affordable Care Act to promote prevention and public health. So we will start with LaMar.
Okay, thanks, Jeff. And good morning, everyone. It's very much a pleasure for us to be included on this panel. So I was asked to think of a few things in the area of research in my organization. So I'm going to go right to the bottom line first, and then I'll back up and tell you a little bit about who we are, what we do, and what our value is and can be. So in terms of the governmental public health, the enterprise, there are the locals, there is the state, and there's the federal government, obviously. So I'm here representing the local health departments largely, and we represent about 3,000 local health departments across the entire country. So bottom line first, final tips, things that I want you to know, if nothing else from my perspective, is number one, you need to make research more accessible to our members. That is local health officials, administrators, and subject matter experts that are working in this enterprise. You got to make it more accessible. So they need to be able to get that research so that they can use it. And sometimes access and cost is a prohibitive factor. That's number one. And number two, I'd say to partner with us. So in the space of public health service practice, research, we are here. We are assets in the community. We interface and convene many actors in the community around community health needs assessments and community health improvement plans, et cetera. We are interfacing with folks and partners and clients all day, every day. We are arguably population health experts because our population is that community, that city, or that county. So we've been in this space, and so I would ask that you think to partner with us in a real and legitimate way, not just, hey, can we get your data, and then maybe list you on the notes section of the research paper, which happens all too often. Okay, so those are the bottom lines first. So let me back up. I got 6 minutes. I think I've used about one. Let me back up and just tell you a little bit about our association. We represent not only nearly 3,000 local health departments, city and county health departments, tribal health departments, and the like. It makes up about 160,000 public health workers or practitioners, and unfortunately shrinking. We've learned that we've lost about 52,000 jobs since 2008, so the pool, the workforce issue is obviously, as well as the pipeline, are obviously chief concerns. Collectively, we serve to protect the health and improve the lives of more than 200 million Americans through the work that we do. What we do as the association, which I am the executive director of, is we assist them in doing their work on the ground. So through capacity building assistance, through a number of different tools and things that we provide for their professional development as public health leaders, and in terms of advocacy that we do on their behalf, giving them a national platform and going to advocate for those policies, those programs, those research dollars, but largely those programmatic and service dollars. All taken together, we catalyze and accelerate the work that they do. So that's why we exist at NACCHO, and we've existed since 1994 in our current form. Now, how do we use research? A couple of different ways. So the association, chiefly we use research in terms of understanding what our members are doing, what our members need. So we have really the only state-of-the-art national database, very rich database of all local health departments. We do something called a national profile. So if you want to know what the workforce composition is, we do another survey called Forces of Change. If you want to know those things that are impacting the way they do their work, if it's ACA, if it's workforce shortage, if it's management criteria, curriculum, or skills, what are the things that's forcing them to get into certain service areas, to divest in other certain areas, service areas, to partner with healthcare delivery systems, or to not partner with them, to be a one-stop shop, or to be a very, very stealth, just core foundational public health factors and elements that they do, such as sanitation and sewage and outbreak diseases. So we have all that data, so we're a data steward, if you will, for all local health, local governmental public health. And so we use research in that way. We also use it in terms of informing the policies that we develop with subject matter experts and with our members. We have more than 40 health advisory boards, committees, and work groups that deal with everything from Ebola to continual population and performance improvement, and everything in between. So we use research to inform our policy papers, our white papers, the guidance that we give to our members as well. Our members obviously are using research, and this is why they need to have access to it in terms of their surveillance and their epidemiology, but also in terms of informing the practice that they do, what's working, what's not working, what are the best and promising practices in the field, and then implementation science. How can they actually do it with some fidelity so they can get replicable outcomes? So that's looking at management science, marketing, organizational, psychology, economics, and the like. That's how they use it. Globally, we use research to look at root causes or associations of some of these very poor health outcomes that we see differentially. We use it to inform practice, shape policy, and to make the value proposition locally, because as you all probably know, the social contract with local health and governmental public health has been eroding. That is, their base of funds and support to do their work has been eroding. There's other field creeps in the space, and there's other things that are happening, dynamic things that are happening that's eroding this contract, this safety net or social contract that has sustained local public health. Priorities. So research priorities from my perspective are, I'm just going to give you two. One is we need evidence, more empirical evidence, to show the impact of upstream and I would say collaborative or joint efforts between public health, the population health experts, and healthcare delivery system. We need evidence that shows what they can do upstream to really impact and really emphasize the role of governmental public health. And we know we have the state innovation model, the SIM projects that are being federally funded, and that's kind of hopefully being incubated for some of these things. But we really need to know what are some of these upstream practices that have a real return on the investment down the road in terms of looking at joint collaborative efforts. These two systems, as you all know, have not worked very well together despite taking care of people that live in the same community. That's number one. Number two, we need research in terms of drivers of and best practices for, again, more innovation between public health and healthcare delivery, approaches to really improve the health of populations beyond, rather, the walls of the facility. So what's happening in terms of that landscape that we call social determinants of health? What's happening there so that we can harvest what we need to improve the health outcomes of these populations? This would include things like workforce development, and alignment and pipeline issues, performance improvement cycles, funding alignment, very importantly, because there need to be some funding incentives. And again, SIM has given us some of these approaches down the road. And then integrated informatics, interoperability. You hear about this all the time. If we can't track a patient from the facility that he or she visits 1 or 2 or 4 times a year to the community where they're spending the other 361 days of the year, then we're going to miss something. So we need to be able to share this information. Last thing is new and better research. We need 2 things, I would argue. We need research in the area of public health financing. Again, there's been an erosion of the social contract. There needs to be some sustainability research, how best to prop up local health departments so we can continue to harvest their value. And what are some of the innovative and alternative models of funding with regards to that. And number 2, in the space of health inequities, in terms of looking at the impact of upstream practices, behavior, structures, policies, things like foreclosures or segregation, be it residential segregation, educational segregation, social inclusion, those things have real health outcomes. I think this audience knows that, but we need that body of research to be more robust so that we can make that proposition in terms of a role, defining a role for my members. Now, I just want to introduce one other thing to you, and that is the Foundation for the Public's Health. You can find that at tfph.org. We have actually launched our own foundation because of the erosion of the social contract and because our members are really hurting to have finances to continue the work that they do. We've actually launched a philanthropic foundation, which is really trying to help all of us as Americans in this space make well on the promise of public health through philanthropy. So we're looking at innovative ways to do that as well. And I think that's my time. Thank you.